Dr.
Okay.
Sandeep Diwan, sir.
Yeah, I think
Hel-
I've met you, is it?
Yes, ma'am. Yes, we met
Yes,
in
I remember.
Hyderabad. Yes.
Correct. Yes, that's nice. Who
Hello,
else
ma'am.
is here?
Myself, Dr. Manisha Gudara. I am an AORA
Okay.
fellow at Sterling Hospitals, Rajkot.
Okay. So Dr. Hetal Vadera's team.
Yes, ma'am.
Very nice. Okay.
Thank you, ma'am.
Good evening,
Ma'am,
ma'am. I'm
myself,
Dr.
Dr. Vishad Shah from Kokilaben Hospital, Mumbai. You are a fellow.
Oh, Dr. Harshal Wagh.
Yes, ma'am.
By the way, Dr. Harshal is my batchmate. Okay.
Okay,
So we have
okay,
done
ma'am.
our MD together.
Okay, ma'am.
Yes, next.
Hello,
Who is
ma'am.
there?
Good
Yes,
evening,
hi.
all. I'm Dr. Deepali from Kokilaben Hospital.
Both of
I
you
have
are from
Dr. Arshal
Kokilat.
Bhatt.
Okay.
Yeah.
Great, great.
Thank you.
Good evening, ma'am. I'm Dr. Shafali from CAS Mumbai. You are a fellow.
From where, sorry?
Uh,
Telling you about what simulation in regional anesthesia is. But as lifelong learners that we are, I would like to introduce you how could you learn with the help of simulation. Okay. And how to learn. I mean, learning is a learner's responsibility many a times, because it's not only the educator's responsibility to teach you. We do have methodologies in simulation that we use, but at the same time, if as a learner you know these methods, you become extremely powerful, because then you can learn from anyone, anywhere. Okay, because you know the method, so you will seek those answers in this particular method. Okay, so simulation is a methodology. It is not a subject. So it's just something that you can apply to any subject that you are learning. So let me begin with the disclosure of no conflict of interest. So, as an understanding of what is simulation, it simply says that it's an experience which is created almost like real, that happens on the clinical floor, and it's created in a simulation lab in a controlled environment where we can pause, we can fast forward, we can stop and say, no, let's discuss this, which is not possible in real life when a surgery is happening. So learning generally happens in a very controlled way. You can pause and think over it, which is amazing, because then there is no pressure that the surgeon is waiting, the patient is deteriorating. All these factors prevent us from really reflecting on what we have learned. Okay, so creating guided experiences that are almost similar to real world helps us really learn in a structured manner, and this helps our brain to restructure the way we think, to bring it out in a much more, you could say, scientific way when we are practicing on patients. All right. So I would like you to think about, how do we as adults learn? Do we learn like children? What do you say, all of you? I need all of you to just talk to me. That makes me feel, oh, I'm not alone. How do children learn and how do adults learn?
by copying others. That's one way.
Okay, so children
Mimicking.
learn by copying adults is what you want to say, right, Shefali?
Mimicking.
Sorry?
Mimicking an activity that they see being performed.
Yes. Okay. So this is, you're talking about children.
Yes, ma'am.
Okay. How about adults? How is it different then?
Adults learn from experience.
Experience.
Yes. For us, कोई अपने को बताएगा कि ये करना है, तो ना you feel, हाँ पता है मुझे, and when you feel that you have learned, from an experience, that stays with us. Yes, Manisha, you wanted to say something?
Yes, ma'am, the same thing. I was saying that we as adults learn from experience.
Right. Okay. So it is intrinsically, we want to know and we learn, and that's how we say, okay, this stays with me. You accept it far more better than being told. And adults are like that. Okay. And they want to learn only what they don't know. What if you know something and the whole thing is told to you again? Let's say you know about a drug called lignocaine. Okay. It's so fundamental for us as regional anesthetists. And you are told about everything about it. and you say, oh, I know 90% of the stuff, but only 10% I learned from this lecture. Okay. So adults don't like that. They like it like a buffet. The learning should be like a buffet. They should be able to pick up, oh, I don't know this, I will learn this. I don't know this, I will learn this. Rest of the things I know, So that is goal directed, only deficit based learning, and they find it much more practical, okay, much more relevant, because they feel, okay, I've got what I wanted. Okay, I've not spent my time knowing things that I already know. Okay, so that happens because they are used to working. They're already doing tasks which they are, doing day to day. And in every day, if they have a problem, particularly regarding that, they are waiting to hear from the educator. Can they solve that problem? Okay, so it also is task oriented, problem centered. It is not like take the whole thing. They want it exactly these are the things. So when we begin a session, many times we ask the learners, what are your challenges? Okay, when they tell us about the challenges, we make it a point that the learning happens with these all points being highlighted. That way, the learners get what they want. So simulation is about that. Okay. So we'll see some references. In medical education, I mean from undergrad to postgrad. Okay, so it's like medical education. There was a critical review done long back, and it still holds true, that what is simulation-based medical education? The research done by William McGaughey and his team said that there are 12 best practices in simulation-based education or learning. Rather than education, I would say learning. Okay, what are the 12 best practices? One, in simulation, you do have time to give feedback or receive feedback, which in real life, sometimes we don't get time. We have one case, we have a second waiting, third waiting, fourth. So we kind of jump, but we truly do not reflect. We do not get time to take feedback from our mentors. Or sometimes the mentors don't have time to give feedback. So this feedback is what is going to improve us. Okay. So feedback time is available. In simulation-based education, we can do deliberate practice. That means I don't want to wait till a patient comes and then I'll learn about the block. Or I don't want to wait to last to really happen in real life and then you will practice, right? So in simulation, create those environment where you can think, can I manage last? Can I manage a nerve block issue, a problem, a communication, the consent? Can I practice that? And the answer is yes. And as many times as you want till you achieve perfect. Okay. Now, curriculum, simulation as a part of curriculum should be there in our learning. Okay, that gives us some breather to adapt to the true clinical environment. So regional anesthesia fellowship program is pretty intensive and it's advanced. But then for some people, when they join this fellowship, they take time to get adapted to this kind of advanced level. And hence, if they have it broken down into compartments which are simple to advanced, becomes simpler. Okay, so curriculum integration is important. With this kind of a simplified learning from simple to complex, we can also measure outcome. Okay, learning outcome. That means, did I learn well? And there are structures. If I learn well at a simple platform, let's say step number 1, if I feel, step number 1, all the criteria I have learned, then I'm really ready to go to step 2. Okay, and that as a learner also you can do. I'm not saying only the educator has to judge you or assess you, but as a learner, you can say, oh, these were the 5 components that I had to learn in step 1. Did I learn that well? Okay, and yes, you can take the feedback from your mentor, but you can also assess yourself. Or we can also have peer assessment. That means these are the 5 points. How did I do? Maybe if you're 2 of your fellows in the same organization, like with Harshal, you're 2 of you. You can actually ask each other and say, let's assess each other. Okay, that can also work. So it gives you opportunity to learn in a very structured way. In clinical, sometimes there are a lot of other extraneous factors which impede our learning. Like I said, lack of time, lack of mentor being around. Sometimes the mentor is there, but the work is so heavy that you need time to give to clinical work, and the learning is expected to happen only in the clinical field. But then the reflection, the thinking, feedback is also important. Lastly, skill once acquired, we say it is permanent. No, it has an expiry date. That means if the same block, if quadratus lumborum, if you have not given this block for next 3 months, you will lose the finesse. You might lose the critical points. You might not recognize the sonoanatomy that effectively. And hence, deliberate practice to maintain your skill is also very important. Skill decay is a very big phenomenon in technical world. Okay, we are all technical people, regional anesthetists. So we need our hands to have that skill. Okay, the kinesthetic skill that we say. And of course, how do we recognize mastery? To master a regional anesthesia, block or a thought process, or as a fellow, we also need time. And that time to master in clinical world could be longer. With help of simulation, you can make that learning curve to be a master shorter. So let's say if it takes a year for you to master regional anesthesia fellowship, with the help of these methods of simulation, you can achieve it earlier. Okay, so you benefit more from that. Transfer to practice. That means what you learn in simulation, am I able to do it in the operating room? Okay, so that transfer is very important. But it helps you. It's like a stepping stone. Simulation is like a stepping stone. Team training. Simulation not only involves only the anesthetist, it also involves the surgeons, the nurses, the OT technicians. And that's how we truly work, right? Like multidisciplinary teams. Simulation gives you an opportunity to interact with them, with their thought process. What do they think? What do they know? And that helps you to become a stronger leader in the team. Okay, so this is team training which becomes stronger in simulation. High stakes testing. I think these are the concepts that you will come to know when you start practicing as a regional anesthetist and make an impact on the organization. Okay, when you go there and say, oh, why don't we give on-arrival blocks? Okay, on-arrival blocks are going to kind of make a difference. So how do we simulate this whole process? In our hospital, we simulate the processes before we truly implement them, and see and examine it from all angles, reflect about it, think as a team. Is it working? What is the cost? How is the patient going to be transferred? How is this patient going to be treated? Everything. And that's called high stakes testing. That means before you invest your money, everything, you test it out. Okay? You test out the systems that you want to build in your organization. As educators and instructors, we do come with sometimes some whims and fancies, and as learners, I'm sure all of you must be feeling, ये कैसा examiner आया है मुझे, and मेरा passing or failing इसके ऊपर dependent है, So I think it's important that all instructors are given simulation training so that they standardize the evaluation. Our exams in AORA, in EDRA, all are standardized. We have these skill sets defined that if the student has these all skill sets and they are very clearly defined, once they are achieved, yes, they are the ones who can be awarded the fellowship or they clear this first quarter, second quarter. If we don't do that, then it becomes far more subjective, and hence objectivity in instructors is very important, and that's what we all as AORA, we are trying to do that. And almost to a 70%, 80%, we are able to achieve it. The next 20% is of the finesse that we are bringing in all the instructors. Also the educational and professional context. Believe me, simulation is applicable to any aspect. Anything that you do, you can learn through simulation. Okay. So this was about medical education. Now let's look at how is simulation viewed in the evidence for teaching ultrasound guided regional anesthesia. Okay, so we are going to see all these 12 best practices. How are they important? So out of the previous 12, these are the ones that have really made, you could say scientific difference, okay, deliberate practice, because blocks, we may not have a surgeon who is open to give blocks, okay, and hence for us to keep our skills in the game or skills up to date, we need to have deliberate practice of the blocks that don't come our way. For example, we might have, times where we do not have much uh, um, advanced blocks like quadratus lumborum. We may not have advanced blocks like thoracic paravertebrals. But does that mean that we will not learn? No, because we have our fundamentals ready, we will use these fundamentals to probably scan our patients, keep the sonoanatomy fresh in our brain, thinking of how needles can be approached, in what probable angles that we can achieve. Keep scanning patients with a lot of anatomic variations, applications. And this deliberate practice can be done on simulators, but at the same time, just by scanning patients, even if you don't want to give that block, still keeps the block in your mind alive. Curriculum integration. See, all the educational objectives are very well defined in most of our AORA, training method. This is what a learner will achieve. Okay. Once this is clear, it becomes very easy to achieve for the learner as well and for the educator as well. No, I'm not learning this way. You can talk to your educator and tutor and ask, can I learn in a different way? And there are different ways as well. Okay. Then skill acquisition and maintenance, team training, and instructor training. All 12 are applicable, but out of these are the ones that show very promising results if you apply these methods, okay, to keep your regional anesthesia absolutely robust. Now, regional anesthesia simulation has 3 parts. One, of course, the education, regional anesthesia education, which hones our knowledge, skills, and attitude. Okay, that is a core principle of every course, undergrad, postgrad, fellowship program, KSA, we call it as, okay, knowledge, skills, and attitude, which means you should know what you're doing. Second, you should know technical skills of your hand. And third, as an attitude, you should know professionalism, communication, convincing a surgeon. Okay, so making decisions, ye block, ye patient ke liye sahi hai. Okay, all these things is about education. Next comes clinical healthcare. That means you truly go on the floor, but you are not alone. You need to take care of this patient as a team. So as a team, how do you work with your surgeons? How do you get him on board? How do you make sure your nurse prepares the regional anesthesia trolley perfectly? How do you assess your blocks with the help of your team? All these teamwork principles can be learned as well. And lastly, system thinking. That means regional anesthesia is for the patient, yes. But if regional anesthesia becomes a part of the mainstream in your organization, that could create wonders. Okay, it could benefit patients who you feel, okay, this is today. But then there could be departments who would like to access these services, but they are not aware of them. So how do you put it in the system that every patient that goes through, that option is available for regional anesthesia, for either pain relief or for anesthesia? Okay, so achieving patient-centric goal, but being a part of the system. And how do you put that? That's like, that's a fellow's job to see in this organization, what is it that I can change in future? Okay, so let's look at one by one. What do you mean by regional anesthesia education? You should know your content. Obviously, there are a lot of content on regional anesthesia through a lot of videos that our fellowship programs put in, of the presentations, of the videos of sonoanatomy, videos of needling, case-based problems, e-learning modules. There are a lot of things that are available to enrich your knowledge. And that's like a one way. It's coming from outside and going in your brain. Okay, that means how will you practice these skills? Do you want to practice them on your patients? Then Sometimes the stress level is higher because वो patient कैसा होगा? We don't know. Is he going to be cooperative? Is he going to allow? Is he fit enough? Is he stable enough for you to have the time to give a block? Okay, so this can be done skill development on simulators, which are mannequins, and you can perform the skill at ease with no cognitive overload. There are no monitors beeping. There are no surgeon sitting and saying time up, 10 minutes mein shuru karna hai. There is no, you could say, the patient complaining. Sometimes you have to remove these extraneous factors for time being to help you learn in a very structured way. In the skill development, we also demonstrate specific steps in which we learn. Okay, so it's not like take the needle, start the block. Okay, it's like more like go introduce yourself, tell what the plan is, take consent. Okay, ask for allergies, rule out contraindications. ये block दे सकते नहीं दे सकते. Okay, and then say, okay, now I feel I've ruled out everything, no contraindications, consent taken, and then you begin the technical part. So largely, there are steps in every skill that we do, be it every individual block or any aspects of managing a case. And lastly, the professional attitude. That means there are a lot of role plays we do. Maybe someday online, we will do some simulation scenarios where we'll interact with each other for communication and we'll see how it benefits. And it's wonderful to learn like that, stress-free, where nobody is here to say, oh, this is not correct, that is not correct. And believe me, nobody is perfect. We all are learning in our different learning environment. Okay, so let's look at how do you increase your knowledge? What are the methods in simulation? Have you all seen virtual reality tables like this? Anybody has seen?
No, ma'am.
Sorry, yeah, yes, Shefali?
Not yet, ma'am.
Okay, so certain medical colleges, certain organizations, they offer these workshops where you can go and play with these tables. These are called as virtual anatomy tables. What does it say? That you can just go and play with the anatomy with them. Okay, the workshops are offered. Now, this is virtual dissection table, the pink one that you see. It's like a cadaver where you can remove each and every muscle layer by layer. You don't need a real cadaver. Now, these all images, if you see, you can also have a cross-sectional view. That means if you decide at this level, at T12, I want a cross-sectional view, like the ultrasound machine gives you, okay, then the ultrasound images are also incorporated in them. So you can immediately look at this level, these are the muscles, and in cross-section, I'm cutting them. So you can actually see the muscle, you can see the nerve, and you can also see them in the longitudinal anatomy too. So it helps you think of anatomy as sonoanatomy, not only as a cross-section, but truly what is it that you're cutting at that point of time. Okay, so this really helps you strengthen your anatomy knowledge, the 3D anatomy that is formed in your brain. So when you see a surface anatomy also, you will say, ye muscle, I need to position well. This is not an adequate position. So this 3D imaging can be utilized to help you understand the anatomy really well. So make use of these. Whenever some workshops are, advised, take opportunity to enroll and look at it. Okay. Then comes the skill development. Now, skill development, like I said, there are standardized checklists we use, which even you can use. Okay, you can take that checklist of a block and say, what will I do first when I have to do the block? Second, third. So many a times you may not require a mentor every time next to you. You can have that checklist and you can say, okay, this is how I will do, and I will practice on a simulator. So it happens either you being alone, the simulator and the checklist, or you could have a peer learner also with you. That means two of you. One holds the checklist and checks whether you're able to do that. So remember, every time your mentor may not be with you because of the current, workload or sometimes availability. Sometimes, it's not like 24/7 you can live with them. But then can you learn on your own using these methods? self work makes you far more confident. And I think that also helps the educator to know that, okay, there is a lot of effort that comes from the learner, and that helps them also to more knowledge. Okay. Spoon feeding is not what educators like. They want to see some effort from the learners as well. Okay. So, yes, we do use formative and summative assessments to achieve all the learners' competence, proficiency, and after that, an expertise. So, your competence means a standard, you will do these in a standard case with no complications, but this is what you will do as a standard. Proficiency means even if the patient is a little complicated, you will be able to do with your professional skills, which are better than competence. And expertise means bring it on, come what may, whatever situation, day or night, any patient, you have achieved that understanding of how will I apply my regional anesthesia skills to this particular patient. Okay, so it's learning and teaching motor skills in regional anesthesia, especially for the skill development, our technical skills development. Okay. So here are the options. So on here, as my cursor, you can see. Can you see my cursor? Can you see my cursor?
Yes, yes, ma'am.
Yes, ma'am.
Yes, ma'am.
So this is a cadaver. Okay. So we do have board of cadaveric studies now by Dr. Sandeep Diwan, where you can actually go scan cadavers, needle them. So this is also a form of simulation. Simulation means what? Recreating like a live. Okay. So even if this is a cadaver, it's recreating situations for you, which is almost near normal. You can see muscles, you can see nerves, you can see your needle, you can see the dye injected in the facial planes. So these are the skills you can practice. So make use of all these workshops to actually go and learn the things that you feel you have not achieved yet. Okay. So as you see, these are the ones that you can utilize. Now, here are the simulators. The simple block also, if you see, this simple block of gel can actually give you ultrasound guided needling techniques in plane, out of plane. So when you join the regional anesthesia fellowship, the fundamentals can be learned here. So that means, am I able to have the visuospatial orientation, hand-eye coordination? Am I able to get this? Because अगर ये नहीं आया ना, तो आगे जाके the blocks may become tough because simply we have stuck at the basic foundational level. So इसको अगर हम hone करते हैं, even with a simple gel block, which is available with almost all ultrasound companies, you ask them to get one and they'll get you, and you can do this n number of times till you have achieved ki I don't need to look at my fingers, because once I have put the needle in the skin, after that I look at the screen and actually can maneuver all the movements. So one is a simple gel block, but there are advanced simulators like these for giving spinal or epidural. Even they might have thoracic epidural inserts here, which you can give all the blocks here too. So these help us practically perform the entire procedure, including consent. That means this simulator is not going to talk, but the educator who is standing here will actually help you talk to them. It's like a role play followed by the entire procedure. Okay. Some of the simulators are very specific, like this one for a tab block. Can you see? Okay. So the tab block also gives you similar conditions, similar planes where our 80 centimeter, 100 centimeter needles can actually be practiced using these simulators. Okay. So make use of these. For example, can you see this is a simple suturing kit, but I have used this long back to secure my catheters. If any one of you are securing catheters, you will know that perineural catheters, you will know how tough they are to maintain in a patient post-operatively. They come out, very easily. So we started practicing all the types of sutures, all the types of tegaderms that we can put. and we would practice on that. So this helped us to find an ideal way, cost-effective way in our system. The next are for skills. If you don't have all these high cost simulators, no worries. There are simple gel phantoms that you can make in your own kitchen. Okay, takes only 2 or 3 hours. Just make like a jelly that you make, you freeze it, you bring out, put another layer, and keep some objects embedded where you can target them on the needle with your needle. Okay, I can share this recipe. You can simply make it at home, take it to your workplace and practice your needling on this. Okay. So tab block, we had also done one study with Dr. Amit Dixit, Dr. Jaya at Ruby Hall, where we saw that using a blue phantom for tab block, we could actually perform or train all the department, and there was an immediate upskilling of all department of anesthesia for tab block. That means not one person is improving, all are improving. Okay, so this is a beauty of simulation where you can improvise everyone at one go. Okay. Now, as regional anesthesia professional or fellows, you are going to be offered all complicated patients. Patients who have low EF, who have a very bad lung, so they are going to be complicated. And hence focus, as AORA is now focusing on teaching all regional anesthesia fellows on focus as well. The reason being, our patients who are going to be with us for regional may be quite sick. And hence, ultrasound guided transthoracic echoes, ultrasound guided central line cannulations. Now that you are a master of ultrasound, तो सब जगह use करना है. Okay, use it. Every patient that comes your way, use ultrasound to make him as safe as possible. Lastly, the professional attitude. That means, how do you take a consent? So tomorrow, if we ever do a simulation scenario online, I'm going to ask you to take my consent. Okay, you're going to come and take my consent online. So we are going to practice these skills using communication. And sometimes the patients are very nice like me, but sometimes the patients can be quite tough. So we are going to have tough communications as well. How do you explain complications? How do you break bad news that you have PDPH and it's not going? Or your nerve has neuropraxia, may take time to go. Maybe temporary, maybe permanent. How will you evaluate? How will you convince them to, not get upset and say, have patience? These all require a lot of experience, a lot of behavioral skills that come with professional attitude. They can be learned in simulation through. 2. So these are some scenarios where we had put in simulated patients. So the one sitting on the chair, we had given them a script and say, okay, this is how you are going to talk to our, students, and they kind of are going to behave as per the skill. So pain assessment, breaking bad news, informed consent, all can be practiced. Now, we'll go to clinical healthcare where team principles are there. There are only 4 things you have to remember in teamwork. 1, how well you manage your task, how well you are aware of what critical situation you are in, how do you make decisions, and lastly, your leadership skills. Imagine that these are the pillars of something called as crisis resource management, CRM, which is a fundamental skill that doctors, healthcare professionals need to have to achieve patient safety. As you can see, task management means competence. You do a spinal also, but you do it with every step being taken care of, irrespective of where crowded environment, noisy environment, or you're giving it in, the pre-op, wherever, but you will do that task the same way. Situational awareness, that means you go to take care of a patient, but you do not have the big picture. Do you have all the information about the picture of the patient? If you don't have, what does situational awareness say? Call for information. Call this person. Tell me more about it, the surgeon, what exactly you will do. Get me the investigations. See the vitals. See the patient. Ask the relatives. Okay, this is what it means. Situational awareness means get as much information as possible from all the sources, even documentation, and then take the decision. If you do not do that, if you're not, that means you have lost situational awareness, that some information was missed out and a decision was made which, affected the patient. Example, platelets nahi dekha, spinal de diya, and then say, oh, when a recent investigation, I forgot to check. Okay, so that's lack of situational awareness. So go to a situation, ask for all information. Okay, clinical decision making. How many options do you have? GA दे सकते हैं, regional central neuraxial दे सकते हैं, block दे सकते हैं. How do you weigh the risk and the benefit? Okay, this is a clinical decision making skill which can be practiced in simulation by reflection, by discussion with the educators or facilitators. Leadership skills. Believe me, these are skills so amazing that once you learn them, you can't unlearn. You just change as a person. And that opportunity doesn't come in the OTs, because there sometimes leadership means to create a conflict. It's like a war between everyone. If I win, I'm a leader. No. If I control, I'm a leader. No. Leadership has different principles, okay, which can be learned through simulation. So as you see here, there are a lot of scenarios that we ran for regional anesthesia. For example, pneumothorax, last, high spinal case scenarios, PDPH, nerve injuries. That involves all these principles as a team, and multidisciplinary teams come together. Surgeons, anesthetists, nurses. Okay, sometimes the scenarios are in the ward for PDPH, nerve injuries. Okay. Now, very importantly, do not forget, simulation does not mean working on a high fidelity simulator. Ek aisa, almost like a robo. I'm working on that simulator. No, it's about, do you do reflection? Now, in this field of education, reflection is the best way to learn. Okay, do you think about what happened? How did it happen? What was it that I did well? What was it I did not do well? And I think I can improve on that. Okay, what were my challenges, my barriers that I can break with the help of my team or with educating myself? And lastly, what did I learn that will prevent me to do that again? And if this is done, which we call it as reflective observation, in our brain, we restructure कि ये block अगले time से मैं ऐसे अलग से better दूंगा या दूंगी. Then you go to that, you give the block again you reflect and think, okay, then you find even finer points. अच्छा, next time तो ये भी मैं कर सकती हूँ. I can position well, I can take well. So every time you become better if you start reflecting after the block is given. Okay, so this is a very important debriefing part, which is the soul of simulation, and that is done after the scenario is over. If we don't do this, we don't learn from simulation. So debriefing is the most important part. Finally, we'll come to system thinking. Now, our systems in India are very, you could say, diverse. Certain organizations have the setup, certain do not. There could be variability. So as you know, there is something called as VUCA. As you see my cursor here, VUCA is volatility, uncertainty, complexity, and ambiguity. Situation is volatile. It can change moment to moment. Uncertainty. Sometimes we work in uncertain situation. We are not sure what is the problem. Okay, but we are diagnosing it. Complexity. Various degrees of complexity can come. Patients, okay, might have ARDS, but mild. Might have ARDS, but severe. Okay, and ambiguity. That means there is absolutely no clarity on what we are dealing with. Okay, so here these factors are there everywhere. In these factors, you have to still achieve standardized care. Okay, and that's why regional anesthesia should not remain restricted to operating rooms. It should be part of everything. Okay, so let's see how it could be. This is my last slide. I'm sorry, I'm overriding and probably I've taken over the whole session. But just to give you an insight into, what can you make as changes once you're a regional anesthesia fellow? Do on-arrival blocks in ER, but for that, simulate the whole thing and show this is how it will happen. And that helps people to buy in. You can help your surgeons to get convinced, oh, acha, it doesn't look that difficult. Okay, it doesn't happen. So simulate either with, a simulated patient, or simulate using a mannequin, simulate using a real patient, only one sample patient, on how it can happen. This is how you can convince surgeons, management. Okay, nerve blocks can also actually enter the field of intensive care units to reduce the opioid requirements, to help them wean from ventilators. These are really amazing, but we don't go there to teach them or to give the patient. So why not explore this? Acute and chronic pain services, be an integral part of that, lead them. Okay. Show how cost reduction can happen with the regional anesthesia services in resource limited hospital setups. Because ultimately, bottom line is money. Wherever you go, management will will it save cost? And can we prove that? If the answer is yes, believe me, you will reach, really amazing statures in the hospital where you govern these services. Improved services in labor analgesia, and of course, in research as well. So take home message today, what I wanted to give you all was regional anesthesia has a wide application, and simulation can actually help you show the world that ये possible है, okay, others, by educating them, in the clinical healthcare and in the systems. And it is pretty much, simulation is a near realistic, goal directed. As you say, adults need goal directed, okay? Goal directed experiential learning. And that is the only one that can engage us and say, I think there is a problem. This is our answer. This is how I will practice. Done. That loophole is solved. Okay. Then you go to the next problem. Okay. So that is it. Thank you, everyone. I'm just going to stop sharing here. And sorry for exceeding the time given to me, but I really wanted all of you to have an overview of what you can use as simulation. Okay, so it's not only the educator, but the learner can also use this. So Sangamitra, do we have time to take few questions?
Yes, sure, ma'am. We are
Yeah.
right on time. No issues, ma'am.
Okay,
I would
so
request all the fellows
all of
to
you.
start your videos so we are all visible to ma'am. And let's have a good heart-to-heart discussion with ma'am.
Yeah. So first of all, I would like you to tell me what are the challenges that you are facing to learn as a student. And as you grow, like a regional anesthesia fellow, you've learned a lot. And this is like, the specialized journey you're taking. So in this journey, are there any challenges that are there which is hampering or is a barrier for your learning? Can you share some with me? And be very free. This is absolutely fine, because once you share the challenge, only we can solve them, right? So do let us know. Just tell me one by one. Yeah, Pooja, you want to say something?
Ma'am, sometimes like in infraclavicular blocks, the needling is become very difficult, like to reach to the below the axillary artery, like towards the posterior cord. So in some of the block, the needling is difficult. Like
Right,
it needs.
right. So the difficulties that come is what you will have to sit and brainstorm. Sometimes even with only the fellows, if you all meet up and okay, what are the methods in which I can improve my needling and to really reach that spot under the artery. So the mentors do help you. They might tell you, okay, but what is it that you want to think about?
Yes.
So this is something that, it's a very good question that you have asked, that this is my challenge. Now take this tiny challenge and attack it. Okay. Think of possible
Yes.
ways in which my needle will go. Then go back to the mentor and say, no, ये method try किया, but ये ना नहीं हो रहा है. The mentor will say, क्यों नहीं हो रहा है? So probably the position, sometimes approaching in a different way, that directly going there, can my fluid, my local anesthetic or my hydrodissection fluid go there instead? And then create that space so that my needle can now go there, So there are various ways in which you can brainstorm and keep trying new methods that suits you. Okay, good.
Yes, ma'am.
Anything else? Anyone
Yes.
else wants to share a challenge and how I'm helping you how to approach? Solutions आपके mentor के पास है और आपके पास होगा. But how do you approach a problem is what I'm going to help you with. Anybody else who wants to share any challenge? Challenge नहीं है किसी के पास? हाँ? So I must congratulate all the mentors. Okay. So every time you give a block now, reflect on it. Okay. Reflect on it. How did it go? What all things did I do? What all things were my challenges? So that you know your strengths. You know, this is my. Only then you can specifically attack them. Your mentor, oh, ये मुझे आना ही है, ये कैसे आएगा? But if you have not reflected on it, okay, if people have to tell you, it's tough, then your day will go bad. आज तूने ऐसा नहीं किया पूजा, तो you will feel like, हाय, ये ब्लॉक मुझे करना ही नहीं है. Okay, ये feeling आता है. But if you reflect, it's much easier.
Okay. Yes, ma'am.
Yeah. Good. So my phone number and email ID is always there. If you have any learning challenges, that means ये प्रॉब्लम है पर मैं ना उसको अप्रोच नहीं कर पा रही हूँ कि हाउ डू आई लर्न फ्रॉम माय मेंटोर, यू कैन कॉल मी.
Yes, ma'am. Thank you,
How
ma'am.
do I ask the right questions for me to learn? Okay. All right. So
Yes.
thank you so much for today, and I really had a good
Thank
time.
you, ma'am. Can I ask something?
Thank you, ma'am.
Thank you, ma'am.
Thank you. So I think I'm going to hand over to Abhishek, right? He's been
Yes, ma'am.
patiently waiting to present. So
Actually, no, ma'am, you had a very good presentation. So I am thinking that now fellows will be bored with mine.
नहीं मतलब I think I ate your time. So
No, ma'am, we are right on time. We allot
Okay.
1 hour for each presenter. It's a 2-hour
Okay.
session. So,
oh, 2 hours. Okay. So
Yes,
I'm
ma'am.
good on time.
yes, ma'am.
So if there are no questions, but then I'm there. अभी नहीं है, but if questions come, you can call me.
Yes, ma'am. You know I will call you.
हाँ, वो तो पता है मुझे. वो तुझे, you are an educator now. So you call for educator questions.
Thank you so much, ma'am.
Thank you.
I know you are not well, and still you have given us 1 hour, and a whole new world. The another aspect of simulation and anesthesia, regional anesthesia, which I think the kid have enjoyed a lot. Thank you so much, ma'am, for joining us today.
Most welcome.
Thank you,
And
ma'am.
the baton of
Thank you, ma'am.
learning is with the learner also. Remember that.
Yes, ma'am.
Okay. So you need to ask the right questions. You need to know what you know and what you don't know. Only then we can progress.
Yes, ma'am.
Okay. Thank you.
Thank you, ma'am.
Thank you,
Can you
ma'am.
please
Thank
provide
you,
the
ma'am.
recipe
Thank
for
you.
the gel,
Sorry?
ma'am? Thank
Sorry.
you.
Dipali, are you asking me a question?
Am I
Dipali?
audible?
Thank you, ma'am.
Thank you.
Am I
So,
audible now?
Yes, Dipali, you are audible. Ma'am is still there.
yeah.
Yes, ma'am. Thank you so much for your guidance, ma'am. I was just saying, please provide that gel recipe, ma'am. You said you will provide.
Yes. रेसिपी भेजती हूँ, आज
Thank you
बना
so
लो.
much, ma'am.
ठीक है. Thank you. Bye everyone. Bye. I'm exiting, Sangamitra. Is it okay?
Yes, ma'am. It's okay, ma'am.
Okay.
Thank you so much, ma'am.
Thank you. Bye.
Bye, ma'am. Abhishek sir, are you ready with your presentation?
So, hello everyone. Myself, Abhishekh Alonikar, and I am at present working as a junior consultant at Sancheti Hospital, Pune. Just a minute, huh? Boss, we are. Hours.
So Dr. Abhishek has done his MD anesthesia and PDCC in pediatric anesthesia from Mumbai and regional anesthesia from McGill University, Quebec, Canada. So sir will talk about regional anesthesia for thoracic surgeries today, innovations and regional anesthesia techniques, evidence-based information. Please continue, Abhishek sir.
So thoracic anesthesia for thoracic surgery is a quite always tricky job, because the topic is itself a big topic. You have to cover the surgeries for breast surgeries, regional anesthesia for breast surgeries, for VATS, for minimally invasive thoracic surgeries, even thoracotomies and sternotomies. So, just a minute. I think I have to. Just tell me, is it visible?
No, Abhishek. Yeah, now it is.
Thank you. So, various types of breast surgeries: breast reduction, mastectomy, reconstructions, augmentation, mastopexies, and breast conversion surgeries. Then for thoracotomies, a couple of incisions which we axillary, vertical, posterior lateral, and sternotomy. Amongst these, the posterior lateral approach is the approach which is more commonly used, as it gives a good exposure to the organs within the ipsilateral hemothorax. While in sternotomy, various types of incisions which are used. Amongst these, I'll say median sternotomy is the commonly used. If you're working in a setup where there is a cardiovascular and thoracic surgeries going on, and also you have a good thoracic team to do the thymectomy and other CA, esophagus, and lung cancer surgeries. Then in video-assisted thoracoscopic surgeries, or VATS, there are two approaches which is used. That is 2-port insertion and 3-port insertion. In 2-port, there is an observation port and an operating port. Usually the operating port, the observation port or the camera port is in the space of 8th rib, while the operating port will be in the 3rd or 4th intercostal space. If they are using the 3rd port, which is the thoracic port, then it may be in the just posterior to the posterior axillary line, which they call it as a thoracic port in the same 3rd or 4th intercostal space. So factors which affect are the type and extent of surgery, the nerve damage due to the metallic retractor, and the damage of the intercostal nerves beneath the thoracotomy due to the pericostal sutures. We have to cover all those things. We have also observed that after thoracic surgeries, many of the times patients land up in the chronic pain due to the nerve damage, intercostal nerve damage, and being a regional anesthesiologist, always it is our responsibility to cope up with the acute pain first, because if we are not able to deal with the acute pain, of course the patient will land into the chronic pain after central sensitization. So we'll go briefly through the nerve supply of the breast and thoracic region. So nerve supply of the breast, it is mainly supplied by the intercostal nerves from T3 to T5, the supraclavicular nerves from the superficial cervical plexus, lateral cutaneous branches of the T4, and an anterior twig of the lateral branch of T2 to T3, which usually forms the intercostal brachial nerve. Innervation of the thorax, there are actually 12 pairs of thoracic spinal nerves, as we all know, dorsal rami and ventral rami. So in the ventral rami, upper two goes to the upper limb, contributing to the intercostal brachial and brachial plexus. Then the next 4 are to the thoracic walls. Lower 5 are combined to the thoracic and abdominal valves, while the 12th nerve usually goes to the abdominal wall and gluteal skin. So the ventral rami, which further extends between the internal intercostal and external intercostal muscles towards the sternum, towards the midline, forming, popping out and forming a cutaneous branch, which is anterior cutaneous branch. Nearby sternum, it is usually accompanied by the internal thoracic, also called as internal mammary artery. While this pattern is seen in all ventral ramis from second to sixth ventral ramis, while 12th and 7th to 12th goes to the anterior abdominal wall. And dorsal rami further dissect or get separated from the ventral rami, and they divide into the medial branch and lateral branch. Various techniques which are used for regional anesthesia in thoracic surgeries are thoracic epidural, thoracic paravertebral, erector spiny plane. Then there comes pectino-intercostal plane block, transversus thoracic muscle plane block, PEX1, PEX2, and also serratus anterior plane block. First, thoracic epidural, as we all know, it is a gold standard used in acute pain management, effective for reducing pain after thoracic and upper abdominal surgeries. A nice diagram. This diagram is from the World Society of Anesthesiology, and there they have shown the insertion and where we insert the thoracic epidural catheters and what all surgeries it will cover the pain in what all surgeries. So if you go in the upper thoracic upper thoracic vertebrae, it will cover for thoracotomy, pectus repair, and thoracic aortic aneurysm repair. The mid-thoracic level epidural insertions goes in the upper abdominal surgeries, useful for esophagectomy, gastrectomy, pancreatectomy, and hepatic resection. While lower abdominal surgeries, we can use the lower thoracic and upper lumbar sites for insertion, useful for abdominal aortic aneurysm repair, colectomy, bowel resection, abdominal perineal surgeries. This is the diagram from the same article. This article, last diagram was the same. Then various solutions which can be used for thoracic epidural. Now here, if we see in all the concentrations, we will have some sort of problems with hemodynamics. There is going to be hemodynamic instability and hypotension. So there is increased risk of neurological injury with the thoracic epidural, and also the incidence of failure or unsuccessful catheter puncture is higher in thoracic epidural, around 1.1% it was. Then also we will see an unintentional dura perforation in the lower thoracic more than in mid and upper thoracic spinal thoracic epidural placements. Then adverse effects such as vomiting, nausea, pruritus, hypotension, urinary retention are always more with the thoracic epidural.
Dr. Abhishekh sir,
yeah.
Can you please make your screen full? Can you please turn on the sides?
I tried to, sir, but I'm not able to change it. I don't know what.
Yeah, now it's better, sir.
Okay, thank you.
Yeah, thank you.
So there was a study which was published in the Journal of Thoracic Surgeries and Cardiothoracic and Vascular Anesthesia by Dr. El Taha from Saudi, and he actually compared the role of thoracic epidural for thoracic surgeries and its perioperative effects. And he found out, gave a key messages as it improves the post-operative pulmonary function, decreasing the duration of mechanical ventilation, less ICU stay, and enhanced patient's recovery post-surgery. Also, he stated that it is not associated with death, myocardial infarction, stroke, and clinically important hypotension after surgery, but it is always associated with impaired detrusor muscle activity, thus increasing the voids, post-void residual, increasing the duration of urinary catheters, thus ultimately leading to increased incidence of UTI and increased length of stay in the hospital or ICU. It has got a negative impact on cardiac output, stroke volume, right ventricular contractility, and voiding of the urine. So another option came up for thoracic epidural catheters or thoracic epidural anesthesia was thoracic paravertebral block. Basically, thoracic paravertebral block is nothing but injecting the drug into the paravertebral space, which is present in the thoracic region, and it is formed The base is formed by the vertebral body. Then the posterolateral is formed by the transverse process and superior costotransverse ligament. Then the anterolateral is does reduce the risk of developing minor complications compared to the thoracic epidural block, is effective same as that of thoracic epidural blockade in controlling acute pain. There is no difference in 30-day mortality, major complications, length of hospital stay, but there was an insufficient data on chronic pain and costs. Then another systematic review and meta-analysis came into the medicine, which was done by our Chinese counterparts, the efficacy of thoracic paravertebral block for thoracoscopic surgeries. And they took into the consideration post-operative 48 hours opioid consumption, even the NRS, and they found out that there is no significant difference between the NRS for first 24 hours, and the opioid consumption was also significantly low, thus stating that thoracic paravertebral block can substantially enhance the pain management for thoracoscopic surgeries. Then these two were the central neuraxial procedures. Now, always these two central neuraxial procedures, we have back of mind, a thought always runs that patient will be running on Clexane, will be on anticoagulants. As these are central neuraxial procedures, they have their own risks, like perioperative infections. Even you can, the thoracic paravertebral catheters are prone to get kink, misplaced during the placement, and you will have like partial action, not a complete blockade of the dermatomes and myotomes which we are supposed to have. So then regional anesthesia techniques came into the picture. These are mostly the interfascial plane blocks in the thoracic surgeries, and these are also mainly used for the breast surgeries more than that of any thoracotomic surgeries. As breast surgery patients are more inclined, or they are more early discharged from the hospital. So PEX 1 and PEX 2 was first explained by Rafael Blanco in Anesthesia in 2011, in which PEX 1, he stated that there will be, we inject the drug between the PEC major and PEC minor, while in PEX 2, we inject between PEC minor and serratus anterior plane. Usually 10 to 15 ml of drug will do. In PEC 2, the difference from PEC minor is that we will be blocking the pectoral along with the intercostobrachial, the intercostals of third and fourth space, and long thoracic nerve. While in PEC 1, we are injecting the drug between the PEC major and minor, we are blocking mainly the lateral pectoral and medial pectoral nerve. Now, in this block, I'll explain the procedure. When the patient is sleeping supine, making the patient sleep in supine, keeping the probe in the mid-clavicular line, we can slide the probe slightly from mid-clavicular line towards the anterior axillary line. While doing so, we have to make sure that we are able to identify all the three layers of muscles around the intercostal space or at the level of third and fourth rib. We will be able to also identify a thoracoacromial artery. Now, while giving this block, always keep in mind, we will not be able to identify the medial pectoral nerve or lateral pectoral nerve. So thoracoacromial artery will be the landmark for it. As there has been anatomical studies stating that in around 80% of the patients, medial pectoral nerve will be accompanied by thoracoacromial artery. So keeping that in mind, we have to inject the medicine that we are not also puncturing the vessels. Then an randomized control trial was published in BJ by a team from BJ Chandigarh, stating the checking for the efficacy of pectoral nerve versus thoracic paravertebral block for radical mastectomy, and they found out that the requirement of rescue analgesia goes significantly down with the pectoral PEX 2 block, and there was also 33% reduction in the total morphine consumption. Then another plane block, which is serratus anterior plane block, I will say is not much of a useful for always useful for mastectomies or radical mastectomies, but it is useful in other thoracic surgeries, even if you wanted to cover the pain for ICD insertions. Also, these are useful for rib fractures. In serratus anterior plane block, it is actually injection of local anesthetic, superficial or deep, to the serratus anterior muscle, and it may reach to intercostobrachial nerve, lateral pectoral nerve, then the thoracodorsal nerve and lateral cutaneous nerves of intercostal nerves of T3 to T9, thus providing almost analgesia for the complete ipsilateral hemothorax. Now, this procedure can be done in the two positions. First, if patient is lying in supine, making sure that patient is lying in supine, keeping the probe in the sagittal plane, and marker, it's up to you. If you're comfortable, you can keep it cephalad or caudad. It's your own orientation, I'll say. So keeping the probe in sagittal position at the mid-clavicular line, sliding it below towards the anterior axillary line. Now, we can do this block even at two levels. If you have got an ICD already on the same side, you will not be able to reach till the level of the latissimus dorsi muscle. So you can go for just below, before the appearance of latissimus dorsi in the picture. But if you go for classical appearance, and if you're asked in the exam about it, you have to say that we have to visualize the latissimus dorsi, which usually lies nearby posterior axillary line. So we have to identify the latissimus dorsi muscle, keeping the probe in the sagittal slightly oblique, and then making the needle go from caudad to cephalad. Now, while injection, you have to keep the needle complete always in the visualization, because high chances you may go beyond and may puncture any vasculature within the intercostal space or pleura, which is the most dreadful combination in this block. And so while injecting, I'll say always have the rib in the short axis, as we see in this picture, and we can use that rib as a safeguard also if you are going deep to the serratus anterior plane. Now, there are always two schools of thoughts. Some say superficial is okay, some say deep is okay. It's up to you. I'll always, if you ask me, I'll say I'll go for deep more than superficial. So always hit the rib if you are going deeper to the serratus anterior plane and inject that drug. Same volume, 15 to 20 ml, will do the magic. Then a modified pectoral nerve block and serratus block, plane block for analgesia in modified radical mastectomy. A randomized control trial was published in the Journal of Pain Research, and they found out that both of the blocks are non-inferior to each other, providing similar analgesia. Then a erector spiny plane block, which was first explained by Forero et al. In 2016 as a novel analgesic technique in thoracic neuropathic pain, basically explained it for post-herpetic neuralgia. And then later on, it became a talk of town in the regional anesthesia for last 3-4 years. In this, actually, we all know the erector spiny plane, we have to inject the drug not on the medial side. Anyone, all can see my cursor? Is my cursor visible?
Yes.
Yes, sir.
Okay.
Yes.
So while doing this block, we have to keep in mind that you are on the lateral 1/3 of the transverse process than going medially, because if you go on the medial side, it will not be an erector spiny plane block, it will be retrolaminar plane block. Now, there are a couple of studies stating that while injecting this medicine, the drug will eventually seep to the ventral rami also. But if you go through good articles published on the biomechanics of interfascial plane block, especially by Ki-Jin Chin, you will find out that all these factors, yes, do play. There are many factors which play part in the spread, including the muscle tone of the patient and the interfascial plane, this how good they get separated. So when you inject, yes, it helps with the dorsal root rami, as we explained, remember, in the first previous slides of the anatomy. So it will act on the medial and lateral twigs of the dorsal rami. Ventral rami depends on the drug. I'll say you have to use some higher volumes like 20 to 30 ml to make sure it goes. Now, erector spiny plane block is still used, widely used for spine surgeries. Decomp, yes. Stabilization, I don't know. In thoracic surgeries, It has been useful for some thoracotomies, mainly posterolateral incision, as I explained in the first few slides. It is useful to cover up the pain because it is mainly acting on the dorsal rami. Then a meta-analysis came for the utility of the erector spiny plane block in the thoracic surgeries, and they found out that yes, thoracic plane block is a non-inferior block for thoracic surgeries, and it brings up, means it fits in the principles of ERAS, serves as an adjunct for non-narcotic control of the pain and chest trauma patients. Then effect of another randomized control trial came in the Journal of Clinical Anesthesia, stating the checking for the effect of perioperative erector spiny plane versus paravertebral blocks in the video-assisted thoracic surgeries, and they found out that ultrasound-guided ESP plane block, when applied before the VATS, was non-inferior in analgesic effect compared with the paravertebral block in terms of pain score, analgesic rescue, consumption, and quality of recovery. Another retrospective case series, as I have told, that it has become a talk of town in regional anesthesia fraternity. Lot of RCTs are there, and even they have stated that in this study, like they stated that thoracic epidural anesthesia, even though it is superior for pain management, but it carries the risk for adverse effects. Thus, ESP can serve as a safe alternative to both thoracic epidural analgesia and paravertebral blocks. In this study, they even compared all other post-operative outcomes, including the pain scores, PONVs, and the PACU complications, the length of stay, then respiratory events and block failure. And they further went on to state that the paravertebral catheters have got a more incidence of PONV in the post-operative period than in the post-op patient-controlled analgesia requirement for the opiates was more in the paravertebral catheters. Then another plane block is transversus thoracis plane block, which is mainly useful for midline incisions, is more helpful, but it can be used for medial rib fractures, and if there is some sparing for after the breast surgery and patient is complaining after mastectomy or any other breast surgeries. In this, basically the probe is kept in the sagittal plane, you making sure that you are seeing all the ribs in the short axis. It is usually done at the third or fourth intercostal space. As we all know, the intercostal spaces are not only intercostal, it has got innermost, inner and external intercostal muscles. So we have to inject just above the innermost intercostal muscles, also known as transversus thoracis muscle. So this carries the highest risk of injecting in going for pneumothorax. Usually this block is to be done in some people are successfully doing it in plane. Honestly, I have never done this. I have never done regional techniques in any cardiac surgeries. But whoever my colleagues or fellows have done, they are saying that doing this block in plane approach is a difficult thing. So better to do it in out of plane, because the rib acts as an impedance to enter the needle into the intercostal space. Then it carries the risk highest is the pneumothorax. Then pneumothorax, also pericardial puncture if you are doing it on the left side, hematoma and dural injury. Then a pilot feasibility study was done for transversus thoracis muscle plane block in cardiac surgeries, and they found out that it is a novel pain management strategy post-sternotomy only, and results in a high patient recruitment, adherence, and satisfaction. Then pectointercostal facial plane block. It is nothing but injecting the muscles, injecting the drug between pectoral muscle and intercostal muscles. Now this can be a bit easier. This block is a bit easier than the transversus thoracis muscle plane block, as your needle is quite superficial to it, and it helps in injecting. It helps in anesthetizing the anterior branches of the intercostal nerves that traverse through the intercostal muscles. Then a randomized control trial was published in Journal of Cardiothoracic and Vascular Anesthesia, which for ultrasound guided pectointercostal facial plane block for post-operative management, and they found out that those who received pectointercostal facial plane block showed a decline in opioid consumption post-operatively, but this difference was not statistically significant when compared with the other blocks for the pain. So take-home message for the thoracic surgeries, as I have already shown this slide, you have to keep in mind the type and extent of the surgeries, as there will be a lot of overlapping amongst the nerves, even the adjacent intercostal nerves passing through, or the nerves passing through the adjacent intercostal spaces. There is always a high chances of nerve damage, not only due to the metallic thoracic retractor they use in thoracic surgeries or minimally invasive thoracic surgeries, but also due to our needle, which we will be passing for the block. And as there will be also chances of intercostal nerves beneath the thoracotomy due to the pericostal sutures, we have to cover the acute pain, because these patients, the one with the intercostal nerve damage, are more prone for for landing into the chronic pain post surgery. This is a nice chart which was there in the World Federation of Society of Anesthesiology, available online, which is helping us to get an overview in single picture what all things and nerves will be covered in all surgeries. Like for lumpectomy, what all nerves you have to cover, what block will be useful. So if you see in the modified radical mastectomy, there will be some patch, like supraclavicular nerves will not be covered by PEX 2. It will also less chances to be covered by PEX 1 also. So we always have to keep in mind that we are using a multimodal part of analgesia technique to cover the pain. But if you are not able to, like some patients are going to show side effects due to the opioids, mainly in cancer patients, because they are already on the neoadjuvant chemotherapies. So you have to consider blocking these nerves also. Thank you. I think it was pretty short as compared to the map.
Thank you, Abhishek sir, for this detailed presentation. I would request fellows to share their thoughts, and if you have any questions, please come forward to Abhishek sir.
Sorry, actually my I don't have a camera access on the desktop in the hospital, so I will not be able to show my face.
Okay, sir.
No questions. Good. So I'm a good teacher, it seems. Chances you will be covering the nerve to latissimus dorsi also. But if you're using it for other like rib fractures, I'd say better to go deep.
Okay. Thank you,
But
sir.
while going deep, you have to be sure that you are able to visualize the tip of needle till the end.
Yes. Also, the drug can percolate through the rib fractures, like the fracture segment. So that's why, so we have to deposit the drug below serratus anterior.
Yes, it usually goes below the, means it usually traverses through the disrupted membrane below.
Okay.
Abhishek sir, my question is, what do you prefer, a sedated or anesthetized patient or a sitting awake patient for your ESPs? I mean, just especially for breast surgeries, what do you prefer?
I learned it in a sitting position. When I did my fellowship, I learned it in a sitting position. We used to do it in the sitting position. But many of times, like novices, when I was a novice, or rather I am still a novice, but I was a novice, I have, means identifying the transverse process is always a headache. To know when the costotransverse junction we have passed, and now this is where we have to inject. So in thoracic, it is always, I'll say, doing it in a sitting position is a better thing to do, because as if you are passing thoracic ESP catheter also, it will be helpful for you to thread the catheter along the plane. But yes, sitting position is always beneficial. Now if you ask me, I'll do it in a lateral position in a sedated patient.
Yes, sir.
But for novice, it is better to do in sitting, at least for fellows.
Any other questions? Or rather, any other doubts or something you all want to share?
Anyone want to correct me? Okay. So thank you.
Thank you, Abhishek sir, for
Thank you,
beautiful
ma'am.
presentation
Thank you
and
for
thought
the
sharing with us
opportunity.
today. And thank you all for fellows for joining today and sharing your thought process. Meanwhile, Dr. Vaibhavi ma'am has shared the recipe on the main AORA WhatsApp group, and I have shared it back into our group also. So try to make those phantoms and try needling practicing at your place, and do share some pics on our group whenever you do or perform that. Okay. Thank you and good night to all of you. We will just
Thank you.
close
Thank you
the
for the
schedule today.
opportunity, ma'am.
Thank you, sir.
Thank you
Thank you,
very
ma'am.
Nice
much.
weekend.
Thank you, sir.
Thank you.